Well, good evening and welcome to Evening Rounds. I'm Dr. Katrina Lee, and I'm a physician in the section of General Obstetrics and Gynecology at the University of Chicago Medicine. In my practice, I provide obstetric and gynecologic care to patients of all ages. Today's session will focus on breastfeeding, where we will be covering breastfeeding benefits, challenges, barriers, and support. Now, this session is part of our continuing education series for OBGYN nurses and medical assistants. We come together this evening with a shared vision. Together, we can elevate the human experience with knowledge and healthcare via a shared mission. As part of the University of Chicago, we pursue globally impactful solutions to seemingly unsolvable challenges through our vigorous and rigorous research, innovative education, and comprehensive care and healing. We collaborate on life-changing advancements that create meaningful results for our community and the world, including a greater, more equitable future for all. We undertake this mission with shared values, excellence, equity, curiosity, collaboration, accountability to make a meaningful impact. I have no disclosures at this time. The objectives of this talk are laid out here. By the end of this talk, participants will be able to describe the benefits of breastfeeding, recognize the challenges of breastfeeding, and implement breastfeeding support. The agenda is as follows. Now, please note that I will use terms such as breastfeeding and mother as used in the reference literature for this talk, but I am referring to all lactating persons. First, we will review some background information. Then we'll move on to epidemiology, followed by some benefits, barriers, medical challenges, then support resources. Historically, breastfeeding has been aptly termed an ancient art and a modern miracle. There are multiple proven benefits of breastfeeding for babies, their mothers, and society. However, social changes in the 20th century led to substantial reductions in the prevalence of breastfeeding in many countries, especially those with high and increasing wealth. Because breastfeeding substitutes were marketed and then viewed as modern and prestigious, whereas breastfeeding was viewed as something that poor people did. Now, concern about this decline in breastfeeding rates prompted research to quantify the benefits of breastfeeding. And this pro-breastfeeding advocacy resulted in the formation of the WHO's International Code of Marketing of Breastfeeding Substitutes in 1981 and other initiatives that helped to reverse this trend. So now breastfeeding rates are increasing, but only 25% of women in the US are exclusively breastfeeding at 6 months. So that's in the US. What we see here is a figure that depicts the global distribution of breastfeeding at 12 months. As you can see, countries with the highest breastfeeding rates are the lower income areas in general, as depicted in the dark green on this picture here. And you can see where the United States falls at about 25%, the lighter green. Now, this graph depicts breastfeeding indicators by country income group, showing once again how low-income countries or regions globally have the higher breastfeeding rates, and resources seem to play a role. Now, this data is for up to 153 countries here in this particular graph. Breastfeeding duration recommendations have been recently updated. It used to be 6 months, but now the American College of Obstetrics and Gynecology, also known as ACOG, as you all know, supports breastfeeding continued breastfeeding while complementary foods are introduced as long as mutually desired by a lactating parent and child for 2 years or beyond. And this recommendation aligns with the American Academy of Pediatrics 2022 updated guidance documenting the benefits of breastfeeding for both the lactating parent and child. Now, we took a glimpse at what is happening globally in terms of breastfeeding rates, intensities, and duration. Now, let's look at what's happening in the U.S. This table illustrates rates of any and exclusive breastfeeding by race and ethnicity among children born in 2017. These percentages beg several questions. Now, as you can see on the left, the initiation rates are good, but why are patients not continuing to breastfeed? The answers, to these questions, lie in the challenges and barriers that patients face in regards to breastfeeding. And also, why are there differences between and amongst races and ethnicities? So, why do we care if patients breastfeed? Well, lactation is an integral part of reproductive physiology, and there are many benefits of breastfeeding as listed on the slide here, such as decreased rate of common childhood infections, such as diarrhea and ear infections, which also results in decreased parental absenteeism from work, decreased rates of childhood obesity in children who were breastfed as infants, decreased rate of necrotizing enterocolitis, decreased risk of sudden infant death syndrome or SIDS, increased bonding between mother and infant, decreased rates of hypertension, hyperlipidemia, type 2 diabetes, cardiovascular disease among women, decreased rates of ovarian and breast cancer in women, improved return to pre-pregnancy weight, and improved birth spacing. Thus, with all these benefits, women are strongly encouraged to breastfeed, and ACOG supports each woman's right to breastfeed. However, also according to ACOG, OB providers should support each woman's informed decision about whether to initiate or continue breastfeeding, recognizing that she is uniquely qualified to decide whether exclusive breastfeeding, mixed feeding, or formula feeding is optimal for her and her infant. Now, we've talked about some of the benefits of breastfeeding. However, what are some of the risks of not breastfeeding? Now, some of the risks of not breastfeeding are deduced or can be deduced from the benefits we've already mentioned. So let's touch on the environmental cost of not breastfeeding. Now, that is actually not yet quantifiable in monetary terms, but we do know that breastfeeding is a natural, renewable food. Breastfeeding is environmentally safe. Breast milk rather, is produced and delivered to the customer, the baby in this case, most instances without pollution or unnecessary waste or packaging. Breast milk substitutes, on the other hand, or formula, do leave an ecological footprint, need energy to manufacture, need fuel for transport and distribution, need fuel or water and cleaning agents for daily preparation and use, and numerous pollutants are generated across this pathway. For instance, it takes 4,000 liters of water to make 1 kilogram of breast milk substitute. So these are important things to keep in mind environmentally. Now, most women are capable of breastfeeding physically, but not all. Additionally, if physically and physiologically able, there can be some contraindications that come into play prohibiting a woman from breastfeeding, like having an infant with galactosemia or a lactating patient being infected with HIV or human T-cell lymphotropic virus type 1 or 2, having active untreated tuberculosis or varicella, having an active herpes simplex virus lesion on the nipple. However, it is important to note that while some patients might be apprehensive to breastfeed while taking certain medications, or might be apprehensive about getting vaccine, or might be apprehensive about breastfeeding while getting appropriate vaccines, it's important to know that most medications and vaccines are safe during breastfeeding with few exceptions. Now, it's also important to know that what's safe in breastfeeding and what's safe in pregnancy can be different. So it's always important to check on what is, if someone asks, what's safe, is this safe in breastfeeding? It's always important to check safety in breastfeeding and not assume it's the same as what the safety would be in pregnancy. Along these lines of contraindications, it's important to clarify what the literature says about substance use in breastfeeding. Specifically, use of medically indicated drugs or treatment for substance use may not be a contraindication to breastfeeding. For instance, lactating patients on stable doses of methadone and the like who are not using illicit drugs and who have no contraindications should be encouraged to breastfeed. And however, of course, if someone is using illicit drugs, they should be discouraged from breastfeeding. Along those lines regarding marijuana, there is insufficient data to evaluate the effects of marijuana use on infants during lactation. However, marijuana use is strongly discouraged while breastfeeding. So how is breastfeeding best supported? Well, as the best supported on multiple levels, starting with the individual level, prenatal education classes are important. Education is key. These classes can be in person, via Zoom, individual or group, in-person support at and around the time of birth by nurses and doctors, and they're taking care of the patient, the lactation consultants and experts that are there at and around the time of birth are all critical in helping to support breastfeeding. There's telephone support that is oftentimes available, particularly postpartum, text-based contact, app-based contact. There's also intense home visits that's sometimes available to some patients, and then multiple one-on-one sessions spanning the prenatal and postpartum periods is sometimes available. For instance, a breastfeeding peer counselor might be someone that's available in some health networks that connect with patients prenatally through postpartum and beyond. And that, helps to improve breastfeeding rates for some patients, the support. There's hospital care and policy level programs such as the 10 Steps to Successful Breastfeeding that a lot of you may be familiar with, and then the Baby Friendly Hospital Initiative, WIC, and other programs. Now, the 10 steps to successful breastfeeding are the broad framework that guide the Baby Friendly Hospital Initiative to support, breastfeeding and bonding. They were developed by a team of global experts and consist of evidence-based practices that have been shown to increase breastfeeding initiation and duration, and were updated in 2018. Baby-friendly hospitals and birthing facilities must adhere to the 10 steps to receive and retain a baby-friendly designation. Now, the 10 steps to successful breastfeeding, as I said, are the evidence-based approach or evidence-based standards of the Baby Friendly Hospital Initiative, which was launched by the WHO and UNICEF to support optimal breastfeeding practices in maternity and newborn care. Now, one of the 10 steps requires compliance with what is called the International Code of Marketing of Breast Milk Substitutes, which requires that no advertising of breast milk substitutes occur to families, and that there be no free samples or supplies in the healthcare system, that there be no promotion of products through healthcare facilities, including no free or low-cost formula, that there be no contact between marketing personnel and mothers, no gifts of personal supply or samples to healthcare workers, no pictures or words that idealizing artificial feeding, including pictures of infants on the labels or products, etc. So this is intended to help ensure that marketing of breastfeeding, or excuse me, of breast milk substitutes don't undermine breastfeeding efforts and support. This slide is a summary of updated directions for implementation of the Baby Friendly Initiative. And again, and I can't stress this enough, the 10 steps is the most important tool hospitals will use to guide their work through the Baby Friendly designation process. So who is supporting patients in this effort to breastfeed? The boots on the ground are, as you would imagine, the providers, which are the physicians and midwives, the physician assistants and nurse practitioners who are caring for the patients, nurses and medical assistants who are helping to care for and support the patients, lactation consultants, and those are your IBCLCs, your ALCs, ANLCs, your breastfeeding counselors, like your certified lactation counselors, certified breastfeeding specialists, certified lactation educators, breastfeeding peer counselors that come from various groups like Health Connect One or La Leche League, breastfeeding educators who support and educate the public but do not necessarily perform clinical care. And then you have like your medical breastfeeding medicine specialists who are physicians with advanced training and experience with breastfeeding management. And of course, there must be administrative support on multiple levels in this team approach to supporting breastfeeding. So let's move on to the challenges and barriers that impact breastfeeding rate, duration, and intensity. I've broken these down into medical challenges and other barriers. So we'll start with engorgement. Engorgement, as you are probably aware, is defined as the physiologic bilateral breast fullness that occurs postpartum, typically or usually day 3 to 5. It's typically the reassuring sign that mature milk is being secreted and involves extension of the alveolar ducts with milk that causes vascular and lymphatic compression that varies in incidence and severity. The breast edema sometimes that patients sometimes experience is different, and that is fluid accumulation in the interstitial space. There's insufficient evidence to support recommending one management regimen over another in helping to relieve engorgement, but early milk expression postpartum may help to prevent engorgement. It can be expectantly managed if symptoms are mild and the infant is able to latch appropriately, but for severe symptoms, referral to a lactation expert or consultant would be appropriate. Now, I will say that some patients do find using a warm pack before feeding and then a cool pack afterwards to be comforting, and then hand expression sometimes is helpful. Persistent pain or nipple injury. Persistent pain or nipple injury is a common or a relatively common cause of early and undesired weaning. And the causes are things such as latch issues. And it's important to assess that if someone has persistent pain or nipple injury, or usually it's the lactation consultant who's, assessing this particular type of issue. But signs of a good latch that, they will be looking for, and helping patients to learn about and to maintain at home are that the infant's chest rests against the mother's body, the infant's chin touches the breast, the infant's tongue is down, the lips go outward. There's little or no areola that is visualized. There's rhythmic sucking is present. Audible swallowing is present. The latch is not uncomfortable or painful, and that the nipple does not appear injured or misshapen after breastfeeding. So, and that's the importance of having multiple levels of support for patients that have multiple levels of support. There's also breast pump trauma that can occur, and again, that education is key in helping patients to prevent that. And then, treatment, of course, would be, using lanolin or hydrogel and things of that nature. Dermatoses are also can be also causes of persistent pain or nipple discomfort, injury. Dermatosis such as eczema or psoriasis, infection like staph infection, and functional pain that can occur, plus a recurrent plugged or blocked ducts, and an oversupply. Low milk supply is another issue that some patients feel challenged with. And perceived or actual milk supply is a common reason for undesired weaning. It's important to reassure patients that the milk supply is adequate if the average feeding frequency is 8 to 12 times per day or more. There's steady weight gain by day 4 to 5, and the baby has 6 to 8 wet diapers per day. And it's important to note that frequent feedings are not necessarily a sign of insufficient milk volume. Now, if an actual low milk supply does exist, the patient can often be supported to feed or express milk more frequently to increase supply. Occasionally, supplementation is needed, either via donor milk or breast milk substitutes under certain conditions, like excessive weight loss, suboptimal infant growth, dehydration, hyperbilirubinemia, and other health and medical conditions. And lactation expert assessment is critical and important. This table lists some conditions that are associated with an increased risk of low or inadequate milk supply. And I won't go through them, all of course, but just so you know that the medical history is very important. It's important to assess the mom's, experience with breastfeeding in a prior pregnancy if it's applicable, because difficulty breastfeeding or slow weight gain with previous children could be associated with an increased risk of low or inadequate milk supply, as well as certain aspects of maternal anatomy, like having tubular breast, which could be a sign of glandular insufficiency, and different antepartum, intrapartum, and postpartum conditions as well. And some more conditions that are associated with a lower or inadequate milk supply. Mastitis. Mastitis is one of the most common complications associated with breastfeeding, defined as a tender, warm, swollen, wedge-shaped area of the breast associated with fever, chills, flu-like aching, and systemic illness. Early recognition and treatment is important because it can help to prevent complications such as breast abscess, sepsis, and early weaning. Treatment includes antibiotics. Most commonly used is dicloxacillin, 500 milligrams 4 times a day, or if penicillin allergic, cefalexin, 500 milligrams by mouth 4 times a day, or clindamycin 300 milligrams by mouth 4 times a day. And a 10 to 14-day course of antibiotics is typically recommended depending on severity. It's important that a frequent and effective milk removal continue during treatment. And if there's no clinical response, one should consider that the patient may have MRSA or an abscess. So an exam is, a clinical exam is important. Other barriers are economic and societal are two big buckets to think about. Economic barriers include things like not being able to afford to get a breast pump, like if insurance doesn't cover it, but usually insurance does cover it. However, sometimes patients don't know how to get it through insurance. So that's where oftentimes our support staff helps us help patients get a breast pump to use. Lactation services are not available to everyone, but they are very helpful. But sometimes patients, for some patients, it's out of reach. And FMLA, having the amount of time off work, amount of protected time off work to be successful is important. But different depending on the patient's job, they may or may not have the amount of leave that would allow them to be successful. And then when they go back to work, sometimes patients don't always have the space or time to or feed. Then there's societal barriers, like there's various stigmas surrounding breastfeeding in certain communities, in some communities, and then there's also equity concerns. One example would be, again, like someone having a job whereby they may not have a private, clean, secure space to pump, or they might not be allotted the time that they need to pump to be able to be successful continuing to breastfeed once they go back to work. This slide nicely summarizes the components of an enabling environment for breastfeeding. It goes over the determinants, social determinants and interventions that and how they interplay to allow for early initiation, which improves rates of exclusive breastfeeding and continued breastfeeding. So this is, just, like I said, just a conceptual model. Okay, these are additional resources for patients and healthcare providers. LactMed is where you can check medication safety and lactation. There are organizations that work on combating workplace discrimination based on pregnancy and family status. And two examples are A Better Balance and Work-Life Law. Findhelp.org is a website where patients can put in their zip code and look for free resources for a number of things, one of which is breastfeeding support, food, all those types of things. So it's a very, very useful website, findhelp.org. And there are also some breastfeeding resources for families of color, like Black Mothers Breastfeeding Association, It's Only Natural. The National Medical Association has breastfeeding information, resources, something for fathers there, Reaching Our Brothers, and Reaching Our Sisters everywhere. So what are our roles in this team approach to care, in our clinical settings? What is the role of the medical assistants and everyone taking care of the patients, particularly outpatients? The role of the medical assistant is, these are some of the things that could be helpful in supporting breastfeeding. Or just infant feeding in general, is to assess the infant feeding method of the parent when they are like triaging or communicating with the patient. and making sure that that patient has what they need to be successful, and reinforcing available resources for support, and completing WIC forms when applicable. And the role of the nurse would be things such as assisting patients with getting breast pumps through insurance, providing education and resources, triaging patients' phone calls when they call with concerns or symptoms or problems, gathering information about symptoms or issues concerning breastfeeding, and then determining the need for an office visit or referral, and communicating that with the patient's provider. And also, it's important to remember the role that social work and our lactation consultants also do a tremendous job in helping us to support breastfeeding, even on the outpatient side as well. Teamwork makes the dream work. So in summary, breastfeeding has benefits for mothers, babies, and society. There are a number of challenges that may inhibit mothers from breastfeeding, but with support, a lot of that can be overcome. Breastfeeding education at all levels, i.e. the practitioner, the patient, healthcare systems, and community, is imperative. A multifaceted approach is most effective in helping to overcome these challenges and to improve our breastfeeding rate. Thank you for your time, and I welcome any questions.
It looks like we've got one question, which is a good one. I was thinking about the same thing, but what are the medications or other ways that patients can increase their milk supply?
That's an excellent question, because the literature doesn't necessarily consistently support the use of specific herbal, like herbs or herbals or medications, but Reglan is one that is sometimes used. Fenugreek is another. Those are two commonly used. That's one herbal and then one medication that will sometimes use to, or I see used to increase milk supply.
And is there that list of resources that you provided was excellent. Do we have a dot phrase for the MAs and nurses to share that with patients, or is there like a single sheet in clinic that we can actually hand to patients as a resource?
That is an excellent question, and currently that does not exist, but we could easily make one.
I think we should. I think that
Yeah.
would be really easy to distribute to patients, and I think it would actually really help our MAs and nurses out too when they're triaging phone calls.
Yeah. And our social worker too.
Yes. I forgot Lexi is there.
Yes.
And then, you talked about many of the barriers and why some patients might stop breastfeeding. Not having, once they have to return to work, not having privacy, et cetera. But would you say that some breastfeeding is better than none? So even if a patient said, I can only do this for 6 weeks, would that be better than them not even trying to do it at all?
Absolutely. Absolutely. Yeah, absolutely. So, and I think it's important during that time to try to make sure we educate patients on the laws surrounding breastfeeding, and that, they do have a right to try in most circumstances to breastfeed when they go back to work, and just make sure that they have a plan in place on how to breastfeed when they go back to work. Some patients just think that they just can't, and that it's important to debunk any like myths surrounding breastfeeding when they return to work.
Does anybody else have any questions? You can turn your microphones on too and ask it yourself or put it in the chat. It looks like not. You did such an excellent job. Everybody's questions were answered. I think probably a big one that they encounter a lot is patients calling with mastitis concerns. Um,
Yes.
and would you say getting patients in quickly to assess what's going on is better than trying to triage at home, or how do you normally counsel the nurses and medical assistants to assist with that?
Yes, that's a great question, and I'm glad I'm gonna have an opportunity to say something about this. So, um, with a high clinical suspicion for mastitis, oftentimes it can be challenging to get patients in right away. So I think that yes, we want to have them come in as soon as possible for an evaluation. But if it's, on the weekend, sometimes we'll start them on antibiotics and have them follow up as soon as they can in the office the following week. But oftentimes what we'll end up doing is starting the antibiotics with the presumed diagnosis of mastitis and having them follow up in the office soon. But it's still important that they do follow up in the office just to make sure that, we're not missing anything, especially if they're not responding.
And then my last question, and then we'll let you go. Thank you for doing this, is pacifiers. And I know I saw it in the presentation. We don't want to do nipple confusion, but sometimes patients are just saying, the baby is just latching on 24/7. My nipples are sore. I just need some rest. Is that going to truly sabotage my efforts? Or, how do we not have patients feeling guilty about things that they probably, I mean, there's enough things in this world to feel guilty about, but is a pacifier one of them?
Exactly. Yeah, it's a very individual decision that lactating patients have to make, and it doesn't necessarily sabotage, you know, an individual person's breastfeeding efforts. And so I think it's important that we approach patients without judgment and be encouraging and just know that, every, lactating diet is unique and that, patients have to do what works best for them and their baby. So I think it's important to encourage patients to do their best. And if that requires that they use a pacifier from time to time, then that is actually usually okay. But it's a very individual thing. I think it's important not to judge patients when they elect to do that for their own well-being.
Oh, somebody asked, what's the best way to store and handle pump breast milk?
Well, it's refrigeration, and sometimes people freeze it. I think the most important thing with that is to not refreeze. I do know that.
And I think you can probably, don't they say you can store it in the freezer for like 3 months? Or did I make that up?
It's several months. I would have to check.
Okay.
But yeah, usually they're asking lactation that. So,
Yeah.
but I know it's several months. I think it's up, yeah, several months.
My
Or
kid is 24, almost 25 now, but I remember like storing all this breast milk from before I had to go back to work. And then my freezer went out, or the electricity went out on the
no,
freezer, right? So I had to like put all of this breast milk in a cooler and ice packs, trying not to get it to thaw out. So
but yeah,
best made plans. Does
yeah,
anybody else
yeah.
have a question at
But yeah,
all?
several months in the freezer.
Several months in the freezer.
Mm-hmm.
Okay.
Mm-hmm.
All right. So I think that might be it. Thank you, Dr. Lee.
Of course, this is all the time we have. Thank you for joining us for this evening round session. We hope the information was valuable and applicable to your work in the clinic and beyond. But please mark your calendars for our next evening rounds, which will be held I have in my calendar, January 5th. The topic will be infertility presented by Dr. Jamie Castillo.